Hi, I'm Sophie Chalmers. I'm a speech and language therapist working in Bolton, and I also hold a clinical academic post with the University of Central Lancashire. I'm currently leading the speech and language therapy pathway within the multidisciplinary long COVID service in Bolton. And this involves the assessment and treatment of individuals with communication, swallowing and voice difficulties following COVID-19. This is obviously a really new area of practice, and so implementing evidence-based practice in this area is absolutely crucial, both for our professional credentials and also for our patients to be able to receive the best possible care that we can provide. So in this lightning talk, I'm going to be illustrating how I've used outcome measures within a new field of practice, specifically at the individual level. So to start off with, I'll briefly recap evidence-based practice in a very new clinical area. We know that evidence-based practice consists of clinical experience and expertise, patient preferences, and the research evidence, and integrating all of those three things. In relation to clinical experiences, in the long COVID service with speech and language therapy needs, we're drawing on lots of different areas from voice to swallowing, cognitive communication, aphasia, psychology, breathing and respiration, and upper airways. Patient preference, of course, is so important with individuals living with these overlapping and complex symptoms that people often describe or have described them as unravelling a ball of spaghetti, or a bit like a game of snakes and ladders where you're taking 2 steps forward and 1 step back. And then we get to the research evidence. In a new area of practice, research is really in its infancy. And in the field of speech and language therapy, there's even less evidence around voice, swallowing and communication changes after COVID. There is evidence from the different medical areas and evidence for more acute populations around the impact and trajectory of COVID symptoms. And absolutely, by all means, we can draw on this. But in the absence of literature, how do we still provide evidence-based practice, or at least contribute to it? And this is something that I've been thinking about. And it's really stemmed from all those questions that the people we work with ask us as professionals. People living with long COVID that come into our clinic often ask us, when will I get better? Will my voice ever be the same? What if this is me forever? They comment that I can't stand this anymore, I can't see the light, and I don't want every day to be a struggle. And this is where I found in my practice that using outcome measures to provide evidence of what we're seeing in our clinics and the patterns and trends that we are observing as clinicians, we can provide really truthful and valid data to better inform and educate the individuals that we see and I see with speech and language therapy needs post-COVID. Recently, I've been piloting the therapy outcome measures for long COVID rehabilitation services in the field of speech and language therapy needs, also in addition to using those validated outcome measures for voice and swallowing. But I've been using those outcome measures to provide that justification of treatment and to also assess changes in health and performance over a period of time. And a lot of services gather therapy outcome measures to look at the impact of their services, but how could we take this a step further in conversations with service users in practice on a daily basis? So I've started using the RCSLT route system to start collating these therapy outcome measures, and I've used some of the reports when it's been appropriate to do so with the people that I see in clinic. And I use this to really explain the trends that I've seen whilst working in the SLT pathway for people post-COVID. Now on the screen is an example of one of the root data analysis diagrams showing that pre and post bar chart of the TOMS scores for individuals with dysphonia. So in this example is just a collation of 24 individuals that have been highlighted by the TOMS with dysphonia. And we can clearly see to date that on this selected cohort of people, over a set period of time, there is a general upwards trajectory in terms of outcomes, and you can see that in the difference of mean and median scores pre and post, and then you get the change level. And absolutely, of course, this is not representative on a national scale yet, but it's just an illustration of the service outcomes from my locality in Bolton. But it does start to give that tangible evidence to people and inform them and keep them up to date in terms of what we're seeing now and how people might be responding to treatment. And I found that, having these honest discussions using evidence of outcome measures really empowering for people, especially in this really new field of practice. So I can also use the TOMS data uploaded onto Root to show individuals of their own performance, perhaps partway through a block of intervention, for example, and show them how far they've come and what progress they're making over a set period of time. And this is definitely a new way of using outcome measures for me personally, and because as prior to this, we've really looked at data on a team and service level to demonstrate impact. And so I would leave you with this. In the field of voice swallowing and communication changes for individuals with long COVID, I've been able to use outcome measures, and specifically TOMS and Root, at an individual level to shine light on the emerging patterns and trends in a new area of practice, and therefore ultimately contributing to the delivery of evidence-based clinical practice for the people I see.